Hi, my hope is to go through these pages pretty quickly. I just finished them up last night, literally at 2 o'clock in the morning. I've got a little over 10 hours worth of work editing these pages, so that's about half an hour per. I put a lot of work into these, trying to make sure what you have is correct, and sometimes you guys find new information, so I have to look it up to make sure that you're reading this information correctly. And I usually try and find pictures or charts or things that maybe you didn't find in there. So these things take me an incredible amount of time to go through. I get that they're taking you a lot of time, and I'm hoping they're worth both of our times. That's my real hope. That going through this exercise helps, one, getting you more knowledgeable about some of these disease states and treatment plans, and how to find treatment plans, and how to find evidence-based work on that. Anyhow, so one of the things I want to bring up first of all is February 7th, we are going down to Columbia for Legislative Day. We're with a bunch of nurse practitioners from the upstate and all around the state, lobbying our legislators to adopt our bill so that we can have more expanded practice here in South Carolina. So if any of you guys can come, that would be great. Just get in touch with me and I'll give you all the information you need. Alright, so we'll start at the very top, stomatitis. So the person who did stomatitis called me because this one is interesting. There is a lot of they're just not going to work today, I guess. There is a lot of different causes for stomatitis. And so, she was like, what do I do? So the most common cause is trauma or viral. So I just kind of pointed that out. She's got a little bit about aphthous ulcers. She's got some good things here as far as treatment, because really there's not a lot you can do to make these feel better. So if that works, great. I've heard of using steroid powder before, but that was new and interesting for me. So anyways, I gave you the recipe for magic mouthwash down here. Just the only thing with that is you can't use it for young kids because it might paralyze their vocal cords and breathing, and they'll aspirate. No, we don't want to do that. Okay, so that's kind of on that one. Otitis externa. This one is a very, very painful disease process, and usually it's caused by bacteria, and usually they call it swimmer's ear because you usually see it after people have been swimming in kind of icky water, and it could be pools that look fine, so just know about that. But it can also be caused from eczema, and you just get like lots of people have just really nasty wax and stuff, but it's usually painful. And so if it's not painful, I wouldn't worry about it too much. So like I had somebody that said were diagnosed, they came into the office and the parent didn't know the child had otitis externa, and the child didn't know, that wasn't complaining of pain or anything like that. But the provider treated it. Probably not necessary, because really one of the hallmarks for this is the pain you see. Okay? Alright, so talking about this, now the medicine they've got here is absolutely fine. This is Ciprodex. Super expensive, like $240 for this thing of medicine. You can get Haloxin, which is about $11, and I've got that in another post later on. And you'll see that if you have any question about how much your medications will cost your patients, look them up on an app called GoodRx. If you haven't got that already, it's great. Prevention, and this is what you want to do. I usually tell them to put a little alcohol in their ears after they get finished swimming. I wanted to make sure that was actually a thing to do, so I looked up a guideline, and they're talking about that you can do that, and they have some other suggestions there as well. So anyway, the other thing with this is that these people don't feel well for a couple of days. So just be informed them that they are not going to feel better for probably 3 or 4 days. It hurts, so give it at least that long before you change treatments, okay? Sometimes these kids have to have wicks placed in there because you can't just get the medicine down into their canal. So you have to put a wick down in there. Sometimes there's just a lot of debris, and I will take just the elephant ear water, like the ear wash, and wash out some of the debris, and that alone will make them feel so much better. Just getting rid of all that pus and exudative stuff that's in there, okay? If it's fungal, sometimes we actually have to use something like Lotrimin powder, and you kind of spray it down inside the ear to get rid of this. So these things can be really nasty. So just be aware of that. I'm gonna have one of those days. All right. Okay. So for otitis externa, this is otitis media. Now this one you're going to see pus in the eardrum. You're really not going to see that unless there's a perforation, and then you will, and then it's otitis externa with perforation, which we talk about later on. All right. The other thing I wanted to tell you about, just remind you, is that babies about 8 months of age find their ears, and they'll start pulling on their ears. They're not running a temp. They're not running a fever. They're not fussy. They're not doing anything else. They're pulling their ears, and the parents will come in a lot, and that's just because they found them and they're like cool handles, something neat to do. All right, so remember the causes: strep pneumoniae, H. influenza, and Captain. I am totally blanking on how to pronounce that at the moment. Anyways, you can see it there, Captain Moralis. Just remember those names, because those are the 3 bacteria. We talked about them in patho. You'll see those names over and over again. I'm sure you'll see them on board somewhere, okay? There are not many to remember, but just remember those. You can also see Pseudomonas and MRSA in the ear, which those are a lot more unusual, thankfully, okay? So this person found an article that says to watch and wait for kids under 2. This article is written in Britain. They do treat otitis media very differently in Europe than they do here. What they'll do is a lot more watchful waiting, because a lot of them are viral, and they'll also perforate the eardrum and just let them drain. But they will do that there rather than treat with antibiotics. In this country, because of the small risk of meningitis, we don't do that. Okay, so just be aware of that. First line treatment for otitis media is amoxicillin. Typically, if there's not been any exposure on a child, you'll use 45. In the cases you do augmentin, then amoxicillin, then augmentin, then ceftonir. Or if you did amoxicillin, ceftonir, then you go to augmentin. So you're going to use those 3 first, and then you kind of move on. So if you got a kid, and we'll talk about this more in pediatrics, but if you got a kid, you're going to bring them back in and make sure that they're clearing up, depending on the age. An adult, they can usually tell you it feels better, so it's not as big of a deal. All right, so she's got some good medications here, and then some examples of ears, and we are getting a really cool tool I'm really excited about sharing with you guys in intensives that is very interactive with looking at middle ears. Okay? But this is just to say, British Journal of Medicine, the British Medical Journal, is actually a really good source, but they do things a little differently when it comes to certain things, and that's one. Normally they're not so different. And then this one was with rupture. So here it's kind of like the this is going to be a lot like an otitis media too, but here now we have access to the pus. So if, for instance, you have someone that's had a ear infection that's been going on forever and you haven't been able to clear it and then they finally rupture, culture it. That's really a cool thing to be able to do because it's easy. It's right there. But normally you don't culture, you just treat it. And you need to bring, if you do have a rupture back, you don't have to see the rupture. If you see the pus, you know you have rupture. But you do need to bring them back to make sure that the eardrum is healing. Every once in a while they have to be patched. So That's unusual, but it does happen. So you just have to watch it. And then here's where I've got the Superdex, $240. Floxin's $11. So just be aware of that. And actually, with otitis externa, you can use something called Codosporin, which is also really cheap. Okie dokie. And then they've got a picture here. This isn't a very good picture of a rupture. I meant to actually try and find one. But actually, you can see a hole in there when you can see the rupture. Sometimes you can see a rupture or you see a hole in the ear because it had tubes fall out and they just haven't healed over. So anyways, that's that. I'm trying to be a little faster today. I'm not for speed, as you guys know. Okay, allergic rhinitis, and this is pretty straightforward. Got a nice little thing here about it and what to look for. And the treatment guidelines changed in November. So I put the new treatment guideline in here so you guys will be aware of that. These are really cool. You don't see very many of them, but when you do, they're pretty cool. And if you can say, "Ooh, I know what that is, I'm going to diagnose it," you'll look pretty spiffy too. These brachial cliff cysts, and it's just basically a remnant, an open cyst that should have closed during fetal life that didn't, and they can get infected and they'll get big, and you usually just see them just past midline. And they're hard and they're red and they're sore, and if you treat them with antibiotics, they will go away, but they'll come back again because you haven't closed the cyst. So those need to have surgical intervention to close. But you do go ahead and do the antibiotics in the meantime because, you know, one, they hurt and they're usually running a fever and then you're going to send them. The surgeon's going to do this a little bit sooner than later. Okay. Here they said ENT surgery. Absolutely, you can send it to ENT. We usually just send it to pediatric surgeons here. Conjunctivitis or to pink eye. I have so many people say, I'll say they have conjunctivitis. Oh, I thought they had the pink eye. Well, you know, that's just the layman's term for conjunctivitis. And you can have conjunctivitis viral, bacterial, or allergies. The allergies are usually itchy. They're usually bilateral, where the other two tend to start unilateral and then progress on. She's got that in here. I put it in here again. She's got polytrim ointment, which is fine. I usually use the drops just because I do. And then the other thing you can try is Vigamox. It's bactericidal rather than bacteriostatic, which is what the ointments are, the polytrim is. So that means that it'll actually kill the bacteria. So it works instead of 7 days, it's 5 days, and it's only 3 times a day, which is a lot easier when you trying to put eye drops in a kid. It's about $40, so it's a little bit more expensive, but you know, depending on their insurance and what's going on. For me, trying to put eye drops in a kid 3 times a day versus 4 to 6 times a day really is a no-brainer. Corneal abrasion. We see these a lot. Not really, we don't see the abrasions a lot. We see a lot of people come in for abrasions. And we will talk this summer about how to do this dye testing, okay? We do it on a grape. It works really well, and it's kind of fun to see. What I really don't mess with eyes. If I think, you know, if there's a corneal abrasion in there, I am going to refer. Now, the thing with this kind of thought that's kind of neat is that you used to think, well, cover the eye up and let it heal, and they're not really thinking that so much anymore, so I think that's kind of interesting. But if there's a corneal abrasion, man, I'm on the phone going to transfer. Or not, well, usually outpatient, but I'm going to send them over to somebody else's office. Okay. All right. Nosebleeds. Another thing you're going to see a lot. Now, this person has a bunch of different reasons why you have nosebleeds. Typically, what I see for nosebleeds is like sinus infections or allergies. Pretty common, especially in young children. I know my kids had them a lot. Then they kind of grow out of them. You can cauterize them. That hurts. So it just kind of depends what's going on there. If it's really bad, you can get a CBC and some clotting studies. Absolutely fine. So this is kind of interesting here. Okay, hearing loss. This is just some interesting tests, and if you don't know how to do these particular tests, and you should have gone over this in assessment, the Weber and Rhine test, make sure you know how to do those because those probably will come up on boards again as well. Just remember that hearing loss is not normal, and she's got a good algorithm here on how to do it, so that works. You shouldn't lose your hearing just because you're older. A lot of people do just because they abuse it, but you don't necessarily have to. Alright, I don't know what those mean. Alright, styes. These can be painful. Sometimes they're not that painful. Typically what you do is just do like warm compresses. You can use a used tea bag, the tannic acid in the used tea bag. The warm tea bag will help kind of soothe it and bring it to a head, and it'll pop. If it's really bad, you can do the antibiotics, but I have never done antibiotics with these. I just let them. Now that one I'd probably do antibiotics. That looks nasty. But usually there's a small one there, and I just kind of leave it alone and let time take care of it, okay? Okay, hoarseness. Hoarseness is a symptom, so you got to figure out why. The most common reason is either overuse or colds or a viral infection or allergies. So, you know, just kind of try and figure it out, because it can be something more concerning, and it also can go along with Parkinson's disease and some other types of diseases they talk about in here. Typically though not. I mean, common's common. So, and one of the things I was told is common even if it presents differently. So, you know, it's probably not, but just think of, you know, keep that in the back of your mind when you have somebody, especially if they're not getting better or don't feel typical to you. Erythitis. This is a medical emergency. They have, if you see this goes, do not pass go straight to the eye doctor. And they have this picture here. That's pretty yuck. They have a little picture of the iris here. This is the typical picture you see with this, with just this red around just right around the iris, okay? So if you see this, if you see this on board, this is something you don't mess with, you send away. Alright. Meniere's disease. Ugh, hate these kind of things. So they've got a nice little write-up on here. I don't think I had a whole lot to add to this, but just kind of read over this, okay? Pharyngitis, or this is tonsillar abscess. So it was pharyngitis, tonsillitis, and peritonsillar abscess. Now the pharyngitis and I have what the difference is between the two here. Just because you hear those words and it's kind of like, well, what are they? So here's the difference between them. But a peritonsillar abscess is a medical emergency. So these things, I've only ever had one kid with one, and that kid looked sick. So I sent him straight over to ENT so they could drain it. But anyways, that's just kind of, you know, you always want to know the red flag stuff. They went through some information on strep pharyngitis, which medication treatments, which we have a strep pharyngitis coming up, so I won't go over that right now. Alright, sinusitis. Pretty much with our case study this week, you should have gone through sinusitis, so hopefully we don't need this. I love the way this is laid out, very easy, clean, neat to see. I love this display here, okay? The time frame is really important for diagnosis, because you'll have people all the time coming in. I've got a runny nose. I think it's a sinus infection. How long have you been sick? 2 days. You gotta go away. But you do need to document that time element there. Now, for instance, if you have somebody with chronic allergies that always have a runny nose, and then they spike a fever and have pain and pressure and that sort of thing, they may not necessarily equate that time frame, because they always have a runny nose, but just for the last 3 days they felt like poop. So, you know, then you kind of, that may be a little different, but typically people come in with a cold and want an antibiotic, which they don't need. Augmentin is the first line treatment. Fluoroquinolones, we really like to reserve the fluoroquinolones. And I'll give you the heads up too with renal stuff too. For the really sick polynephritis, the really sick, resistant people, we don't like to throw around the fluoroquinolones. One, they have a pretty good side effect profile, especially in children, and two, they have they can become resistant pretty fast. So we like to save those for when we really need them. Okay, strep pharyngitis, kind of just talked about that a few minutes ago. So this is a picture they have in there, which is a picture you see a lot with strep. This is what I usually see strep looking like, the red petechial back of the throat type thing, or the red beefy tongue, sandpaper rash on their chest. So basically, if I think it might be strep, I check it. I have seen strep with no sore throat, so I've got a thing. If they have fever, a headache, and a stomach ache, and sore throat. So if they have any of those three of those things, whether if they have a headache, stomach ache, sore throat, no fever. If they have a sore throat, a stomach ache, a fever, you know, I get a strep test. So any of those four combination things, I get a strep test because, you know, very likely it's going to be positive. The other thing, that's kind of weirdo things that you can see with strep is if you have joint pain, particularly if you have migrating joint pain. My knee hurts today, my other knee hurts tomorrow, and the kid's limping on one side, then limping on the other. Do a strep. You'd be surprised that can cause it as well. The other thing you can see is a strep A diaper rash. And if you've never seen it, somebody described it the way it looks, and I thought this was so good. It's how you get bologna that's been sitting in the refrigerator a little too long, kind of slimy, and you pull one from the other, and it kind of makes a slime layer between them. That's what their butt cheeks look like. So if you see that, just do a rapid strep test on their hiney, and it, you know, then you know how to treat it, and you'll look really smart. Okie dokie. Tinnitus. I have a daughter with this, and this is, you know, just an awful thing because there's really not a lot to do about it. The biggest thing you want to do is make sure you don't have any bad reasons for having it. Now, they've had here that it's not heard by the provider, but you can. There is a very small subset where you can actually hear it by the provider. This is not a good thing when you can hear it, okay? Because that means there's something organic going on, so we need to figure that out. So if you can actually hear ringing coming from their head, we need, you know, that's something you need to know. But usually it's not. It's usually the person hears it, and it's usually unilateral. If it's bilateral, then it's a little bit more concerning as well. So you want to take a good drug history because some drugs can induce this for sure. All right. And last but not least, TMJ. See a lot of this, especially, you know, the type A kind of kids, especially see college age kids, type A people. They grind their teeth at night, so they get this terrible jaw pain and can't open their mouth, and sometimes they need steroids, but anti-inflammatories work well. Those little mouth guards work well, like a dental appliance. You can get them to try the over-the-counter if they can't afford the ones from the dentist, which are super expensive. So anyways, this is it. Well, I kept it down to 25 minutes. All right, guys, thank you, and talk to you next